Okay, welcome to the reproductive system. This is our week 9 content that was swapped at one point, week 10 and week 9. I have a sneaking suspicion that a lot of textbooks put the reproductive system at the end to hide it, and a lot of lecturers put it at the end of the semester just in case like they miss a day and they have to cut some content, then they don't have to talk about naughty bits. I feel the opposite way of that. I think it's a very, very important system. In anatomical sciences, it gets exactly equal attention compared to every other system. It is just as important as every other system, if not more so, because so many people have a hard time talking about it. And that's another one of my, not caveats, my little warnings for this lecture. If you have your mind blown today, it's not your fault. It is the fault of the K through 12 education system and how poorly educated our kids are before they get to college. You should not be in a college level course before you understand how reproduction works, and that is my very solid belief and why I refuse to feel any shame about this. Another side note is slang terms for naughty bits for reproductive anatomy is perfectly acceptable. Not in a lab practical content, but in a real world. Like, your patients are going to come to you, your future patients are going to come to you, and they're going to talk about their hoo-has and their danglies and whatever else, and that has to be fine. That is perfectly acceptable. Language is a flexible thing, so we're never going to shame anybody for using weird slang for that. Including during our lecture, but not on the lab practical. Lab practical's different rules. So, overview of the reproductive system. This textbook happens to start with female reproductive anatomy. It is the first textbook I've ever worked with that actually starts with female reproductive anatomy, and I'm very proud of it for that fact. Then we'll cover the male reproductive system. There's a certain amount of overlap, especially with the hormones. Some of the terminology follows over, not all of it. The primary sex organs are the gonads, which is probably a clearer way to say that would be that the reproductive organs are the gonads. That's where the eggs, the oocytes, are developed in females, and the testes develop sperm in males, and those are both gonads. They produce gametes. The oocyte is the female gamete, the sperm is the male gamete. And there are lots of series of tubes involved. They have ducts to transport gametes from gonads to sites of fertilization. So again, we are starting with female reproductive anatomy, and this is the mid-sagittal view. There will be multiple views for female reproductive anatomy, and one of the things we're going to do today is we're going to count the holes. And we're going to count the holes in part because maybe somebody today is going to get their mind blown, and because definitely your patients do not know how many holes they have. That is going to be something you encounter one day. So the external urethral orifice is going to have overlap with our urinary content next week. That's hole number 1 for females. You go a little posterior to that, there's the vaginal orifice. And you go posterior to that, and that's the anal orifice. So that's 3 holes for women. 1, 2, 3. Okay. So that's our starting point. Externally, you can sort of see from the side view the labia, but it's not the best view to test labia from. The vagina is strictly an internal feature. This vagina is internal. Nobody saw Britney Spears' vagina back in 2006 except for her obstetrician and or gynecologist. Unless you've got a speculum, you're not seeing vaginas left and right. The external female anatomy is known as the vulva, and those clinical terms are significant in their difference. I know it's a colloquial thing to refer to female genitalia as vagina, but it is not medically accurate. So again, that vagina is strictly internal. That gives way to the cervix of the uterus. There is a cervical os here, which is an opening into the internal environment of the uterus. Notice that this uterus is tilted to the anterior position over the urinary bladder, which is super great for all of us women in many ways. And then over here we'll have the uterine tubes / fallopian tubes. I think the preferred term these days is uterine tube, and the ovary over here. You can see the glands of the clitoris right here, but it is a massive mistake to refer to just this little bit as the clitoris, and we'll get more into that later with a little bit more man bashing. It'll be great. Accessory sex organs also include the mammary glands. That is considered a secondary sexual characteristic for people who are genetically female. Now, the uterus isn't just flopping around in there. We used to think that the uterus wandered around, but that was wrong. It actually is suspended by a series of ligaments, conveniently known as the suspensory ligaments of the uterus. They do have specific names like the broad ligament, the ovarian ligament, for example. You'll also notice there's a ureter that's sort of embedded in these suspensory ligaments. Down here, this will be known as the round ligament, and I do have a different image to clarify that round ligament. If you have ever been pregnant or you know pregnant people, they may have complained of round ligament pain. That would be the stretching of this ligament right here as the uterus grows in the superior direction. This over here is a cross-section of an ovary. You can see how there is a connective tissue. It's known as the mesovarium. That's not one of your vocab words, I believe. Connecting it to the suspensory ligaments, so it is held in place. It's not just floating. And that ovary will have a tunic. It's going to have a sort of germinal epithelium, and in addition to that, it's got something called a tunica albuginea. That root word there is white, albino, albuginea. So there's a sort of white capsule around this. This is an encapsulated structure. And we will have some more specific images for the development of both the egg, the oocyte, and the follicle, which surrounds the egg. That's coming up. This is an anterosuperior view, looking down into the pelvic cavity from the abdominal region. And you can see the relationship between the urinary bladder and the uterus, and this is a relatively small uterus. It does shrink with age. Okay, we did that. The ovaries also have a cortex and a medulla. The cortex is going to be the site of development of follicles and oocytes, where the medulla is going to be a source of nerves, arteries, and veins. So more detail here. It may already be clear that I am differentiating between follicles and oocytes. Oocyte is the single cell that is that germinal cell, that is that reproductive cell, but it's surrounded by other cells that support it. And they both are going to develop throughout a monthly cycle. So you start with primordial follicles, and during each monthly cycle, a handful of primordial follicles will develop into primary follicles. That is development of the follicle. Within that primary follicle, there will be a primary oocyte. We will talk in detail about primary, secondary oocytes and how they develop separately. That follicle continues to develop. Generally, we select, so to speak, one egg fully develops during the course of a human monthly cycle. So one is selected to become a secondary follicle, which then matures into a mature follicle, and that will happen right before ovulation. This is an image representing ovulation. The oocyte is released from the mature follicle during ovulation. Now the follicle stays behind, and the follicle is going to degrade into a structure known as the corpus luteum, and that translates to golden body. It has a very yellow appearance in histology. The job of the corpus luteum is going to be to secrete the hormone progesterone, and that progesterone is going to support implantation and support a developing embryo should implantation occur. If fertilization and implantation do not occur, that corpus luteum degrades into something known as the corpus albicans. And again, we've got that albino prefix there saying it's a white body now. So it goes from gold and it degrades into white. And that corpus albicans is scar tissue. So every month that women ovulate, which, you know, if we're on various forms of birth control, we may not be ovulating. Every month that a woman ovulates, she's going to develop more and more scar tissue in the ovaries. So that is absolutely true. It is just withering away into nothing. That's not a cultural lie. Unfortunately.
What is it? What hormone does it produce?
The corpus luteum produces progesterone.
So to clarify, it goes primordial follicles to primary follicles to secondary follicle to mature follicle. And is the corpus luteum separate, or that is a...
The follicle remains and degrades into corpus luteum.
Okay, and that's where it makes progesterone?
Synthesizes and releases progesterone, yes. Well said. I will warn you, if you look at outside sources, this has multiple names. In fact, many of these have multiple names, especially the mature follicle. Sometimes I slip up and call it the Graafian follicle, because that's what I was taught. So, and again, as usual, I will try to have both names on an exam context for that.
So it becomes the corpus albicans if it's not...
If implantation does not occur, it will degrade into a piece of scar tissue known as the corpus albicans. Primordial, primary, secondary. Vesicular just means it's starting to develop a vesicle, which means a fluid-filled space. And then a corpus luteum and then a corpus albicans after ovulation. To an extent, I expect you to be able to recognize these histologically, probably on a more collective picture. But I do have specific examples for you. So primordial follicles are basically just a simple squamous epithelium surrounding an oocyte. As they develop into primary follicles, they develop a couple of cuboidal layers. Secondary follicles, you do need to know the zona pellucida and corona radiata. Probably not from this picture. A picture like this would be great though. So immediately around the oocyte, you're going to see like a little halo shape, and that's going to be the zona pellucida. Radiating around that zona pellucida, the slightly darker cells, are going to be the corona radiata. How do you want to translate corona radiata? Yeah, a radiating crown around it. So I always kind of, if I'm sketching this, I always kind of draw it like it's radiating out with a bunch of lines. So again, from deep to superficial, zona pellucida, then corona radiata. And I mentioned a vesicle. A vesicle is a fluid-filled space. We actually refer to that as the antrum of a developing follicle. So here's a Graafian follicle. You can see the oocyte is just where my red dot is right now. It's relatively small compared to all of the support cells that have developed around it. Here's a better, in my opinion, picture of the Graafian or mature follicle. And you can see again that zona pellucida and the corona radiata around it in this image. And there's that antrum. Fluid-filled space right there. This is probably not a human ovary. Does anybody want to tell me why? Size, actually that's pretty in centimeters. I've seen them that small before. Can anybody recognize what this is already? I know it's early days and you just had an exam, but there is something specific that is represented by both that and by that. It is. Those are two corpus luteum. So this is just post-ovulatory, and the follicular cells are already becoming corpus luteum, and there's a remaining corpus luteum. Why does that mean it's probably not human? Yeah, they've ovulated twice in one cycle. Because otherwise, if you ovulate twice in one cycle, you could have two corpus luteum, if you specifically ovulated two. But you would generally not have one degrading while another one is just forming. Any animal that has multiple births. I mean, yeah, we can have twins technically, but they would have ovulated at the same time. Yeah, it's something that has a litter. Okay, corpus luteum, corpus albicans. We can prove that the corpus luteum does stain darker than the corpus albicans. These cells are scar tissue. They do not function in terms of They don't have a reproductive function. They're just left over. Now, within the ovaries, we've talked about follicular development, and that happens in parallel with oocyte development, oogenesis. And you're going to see another parallel to this in spermatogenesis. It's going to work in a very, very similar but not identical fashion. Do you guys remember haploid and diploid? What do I mean by haploid and diploid? Most of the cells in your body, are they haploid or diploid? You've got a 50-50 chance.
Haploid.
No, diploid. Thank you for speaking.
Scream out the right answer.
All right, so the answer is diploid. Normally, we have 2 sets of chromosomes in every cell in our body. That's our normal state. You got 1 set of chromosomes from mom, and you got 1 set of chromosomes from dad, and now you've got 2 pairs of 23 chromosomes to work with. And that's known as a cell being diploid, and it's got 2 sets. So by that logic, what do you think haploid is? 1 set of chromosomes. So haploid means you only have 1 set of chromosomes. Your gametes are haploid. They have to be, because that egg is going to meet a sperm cell, and then each will carry 1 copy of chromosomes from the parent. They join together, and that's the new diploid cell. That's the new, like, fully got all the sets of instructions cell that's going to become the embryo and then the fetus, the conceptus embryo fetus. So far, so good? Okay. So you're going to start with a diploid oogonium. And that's simply going to undergo mitosis. And we know about mitosis, it produces 2 genetically identical daughter cells. At this point, we're going to call that a primary oocyte. That primary oocyte is going to be arrested in meiosis 1 throughout childhood. Women, you are born with every single egg you will ever have in your life. We've already got them in there. Your eggs developed while you were still in your mother's womb, and her eggs were developed while she was still in her mother's womb, and so on and so forth up into infinity. So they start meiosis 1 as primary oocytes. They are arrested in meiosis 1 throughout childhood. So once upon a time, you had to learn about meiosis. You learned meiosis 1 happens, then meiosis 2 happens. They didn't tell you anything about timing. They didn't tell you that it could just stop and stay there throughout your entire childhood. But it does, at least for female oocytes. Now, every month throughout the menstrual cycle, ovarian cycle, uterine cycle, certain eggs will be selected to develop. And that 1 egg, generally we're going to finish with 1 egg, right? That 1 egg finishes meiosis 1. And then it's going to start meiosis 2, and then it will stop in meiosis 2 during that monthly cycle. Now here's the fun bit. It's not even well illustrated there, I just noticed that. Okay. After meiosis 1 completed, the process of meiosis 1 split that into, generally we say 2 daughter cells at that stage, and then there's round 2 and that does another 2. Do you guys remember that? The goal of meiosis is to get 4 genetically varied daughter cells overall. You guys remember that? Does that ring a bell? Do we need to review meiosis?
Yes.
Yes, we need to review meiosis. All right, let's take a step back and review meiosis. The goal of meiosis is to produce gametes. You have 2 stages, meiosis 1, meiosis 2. It's not complete until both are done. The process of meiosis will ultimately get you from diploid to haploid, right? Meiosis 1 occurs, you have 2 genetically varied daughter cells. Meiosis 2, those both split into 2 genetically varied daughter cells. That's our standard meiosis. And we're ignoring, prophase, metaphase, anaphase, telophase, all that stuff. But that's in meiosis as well. Now here's the thing. That 4 genetically varied daughter cells is true for precisely half the population. Guess which half? Men. Of course, it's true for men. For women, when we finish meiosis 1, we have 1 daughter cell and some cast-off chromosomes. It's called a polar body. After meiosis 2, same thing. 1 daughter cell that is different from the cell that was up here, and 1 cast-off polar body. So what you learned in high school about meiosis was 50% a lie. That's what we're getting at. And it's 50% a lie that, as always, favors men. Okay, so instead of having 4 genetically varied daughter cells, we have 1 daughter cell that is slightly different than that oogonium that we started with. Meiosis 1 started before childhood. It didn't complete until that egg was chosen during the course of a monthly cycle. After meiosis 1, it started meiosis 2, and it is arrested in meiosis 2. This part's very important. Meiosis 2 does not complete unless the egg is fertilized. If you have never had an egg fertilized, your eggs have never finished meiosis 2. That timing is important in terms of fertility, because this meiosis 1 being arrested for such a long period means every childhood x-ray, every CT scan, every exposure to radiation that you had as a kid, or toxins, or whatever, that gets stored in your body, and it could potentially affect fertility. Meiosis is going to be a site of non-disjunction disorders. This is how we get abnormal numbers of chromosomes. Yes?
Is that like how some people, when they give birth when they're older, their kids might have like some issues?
Yeah, that's exactly what Down syndrome is a trisomy, which means they have 3 copies of a chromosome, which means there was a problem in meiosis and the chromosomes didn't split correctly. So it sounds like I'm blaming women for all non-disjunction disorders. This is happening continuously in the male reproductive system as well. So any event that causes irradiation to men can also cause those non-disjunction disorders. Chris, question?
So isn't there, I can't remember exactly, but like, isn't there a process where the cell before it starts to like divide, like it has checkpoints, and if there's something wrong, like it'll destroy the cell?
Potentially, yes. So there are, and I think you're mainly thinking about interphase for mitosis, which is a little bit different than gamete cells, as far as I understand it. So potentially, yeah, a gamete with mutated DNA, potentially there would be apoptosis there. The issue is if there's not, and the sperm meets that egg. Most of the time, the majority of time, the result of this is going to be spontaneous abortion, or miscarriage is the other term for that. So just, yeah, and I'm going to get rid of that taboo word right now. Miscarriage is unbelievably common. Our best guess at it is about 25% of pregnancies end in miscarriage in the first 12 weeks. It's a massive, massive, massive number. And that's just our best guess. It's probably even higher than that in terms of eggs that are fertilized and simply do not implant. And I'll explain why that is in just a bit. And overwhelmingly, miscarriage is caused by this, by non-disjunction issues, chromosomal abnormalities, mutations to the DNA, because we do carry our gametes forever. And again, with men, it can happen with men too, any sudden exposure to toxic things or to radiology or radiation, whatever.
So is all this occurring before the 12-week gestation? Because once you hit the 12 weeks, then that...
So oogenesis is specifically before fertilization. So this arrested in meiosis 2, and we have right here, let's see, primary oocyte, secondary oocyte. So your secondary oocyte is what gets ovulated, and then it potentially could be fertilized at that stage. And then we have a conceptus, and we haven't even gotten into embryology at that point. Does that make sense?
Yeah.
So this is even, like, ovulation occurs right here on this
So those
edge.
miscarriages that you're talking about are like before they even knew they were pregnant?
Yeah, potentially before you even knew you were pregnant, you had some chromosomal abnormalities.
Okay.
Absolutely. Same with sperm. Okay, let's say that ovulation occurred and let's say there was fertilization. Fertilization is actually supposed to happen in the uterine tubes, not in the uterus, and there's a very specific reason for that. So within your uterine tube, you have fimbriae. There are little fingers at the ends of the uterine tubes that try to usher that oocyte into the uterine tubes, because they're not actually inside there yet, right? There's not a direct connection. This is the peritoneal cavity out here. You ovulate into your peritoneal cavity. And there's no guarantee that you're actually going to get that egg into the uterine tubes. So those fimbriae are there to usher them in and say, come this way, buddy. This is where you belong. And hopefully that works. It doesn't always. Next, they're going to meet the infundibulum, then the ampulla, and then the isthmus of the uterine tube. And that's about a 3 to 5 journey for a single egg cell. The lining of that uterine tube is ciliated, so it will be washing that egg down towards the uterus. Now we want fertilization to occur out here because that 3 to 5 journey, that conceptus is going to be developing cell layers, and it specifically has to develop a layer known as the trophoblast layer. This is not one of your vocab words. This is your important for life, and because politics likes to get into this, knowledge and understanding of what's actually happening here. You need a trophoblast layer in order for implantation to occur. It's a specific cellular process where that egg has to embed inside of the endometrium of the uterus. That takes cellular skills, so to speak, right? For that layer to embed itself. That conceptus does not have those skills to embed itself until it has the trophoblast layer. So if you were fertilized down here, if sperm meets eggs down here, and it doesn't have 3 to 5 days to hang around, maybe you start menstruation, that fertilized egg will be flushed out with menstruation. That happens probably on a very regular basis for people who are not on birth control. It's not a political statement, it's science, and I'm stopping there. Okay, those uterine tubes do have our good old friends mucosa muscularis and a serosa, which means that's going to be a little bit more exposed to the environment as opposed to embedded in its separate organ. You can see some histology of uterine tubes up here. If you look very closely, you will see a simple columnar, I believe. Is that pseudostratified? It is simple ciliated columnar epithelium that is waving that egg down. It's actually really cool. A student had a question about this last quarter, and we ended up finding out that in a fertile woman, those cilia will move one direction if there's the presence of sperm. It'll actually push the sperm towards the egg if you've just ovulated. And then after ovulation, the cilia reverse direction and push the egg towards the uterus. Isn't that cool?
That's cool.
Yeah, and that's a factor that affects fertility, so because some people will have less ciliary motility or issues that affect that. Now let's say that that fertilized egg made it to the uterus. Let's say it developed a trophoblast layer. We want it to implant up here in the higher part of the body of the uterus, close to the fundus of the uterus. I promised you there would be more funduses. Here's another fundus. The top rounded portion, we want implantation to happen relatively high up. Body of the uterus, the thinner portion, when it starts to thin, we call that the isthmus of the uterus. And then down here is the cervix and the cervical opening here. It is pear-shaped. It is highly variable in size based on age and fertility. A recently pregnant woman would have a uterus the size of a cantaloupe. An elderly person has a uterus that's like this big. They're tiny. What else do I want to say? Your textbook has some great terminology here. The role of the uterus is the site of implantation of a fertilized egg, assuming it got that trophoblast layer. Supports and protects the developing embryo or fetus. It's an embryo for 12 weeks, and then the rest of the time it's a fetus until birth. And then here's my favorite terminology, ejects the fetus during labor. And I just imagine pressing that eject button, like, and it just, and it's, if only it was that easy, but no. Isn't that great? As always, we've got 3 layers of the uterus. The endometrium is the site of implantation, so it's going to be the lumen side. It's going to be the hollow inside internal surface. And it's also variable in thickness throughout the monthly cycle. The myometrium is the muscular layer. Those are where you're going to have contractions for childbirth. And the perimetrium is just going to be the most external layer. Now that endometrium, like I mentioned, is variable in size. It will contain uterine glands, and that's actually quite variable because there's a basal layer that stays the same. You always have the basal layer of the endometrium. The functional layer is what changes in size and depth. So you have these development. Here's your uterine glands. They increase in size during a monthly cycle until menstruation. This is what sloughs away, and this is why bleeding occurs, because they are very vascular. So it's not just blood, it is uterine wall lining as well. So you have uterine cycles. In addition to your menstrual cycle, ovarian cycle, you have menstrual uterine cycles. There's a proliferative phase. So after menstruation ends, the beginning of your cycle begins. Proliferative phase means the endometrium is proliferating. It is thickening in size. We need a very thick endometrium for implantation of that fertilized egg to be successful. If an egg is fertilized but it meets up with this part right here, it's not going to work out. It's going to be flushed with menstruation. If it meets it here, it's not going to have enough space to embed into. And it's not going to have the nourishing environment of the uterine glands and vasculature. So that egg has to meet up with this in the secretory phase. What's being secreted in the secretory phase is that progesterone from the corpus luteum. It's the progesterone from the corpus luteum that keeps the endometrium around. So that endometrium stays nice and thick in the presence of elevated progesterone and estrogen. Sound good to everyone? It's an important detail because what's in birth control pills? Progesterone and estrogen. What birth control pills are doing is they are mimicking the hormonal state after ovulation. It's not mimicking pregnancy, it's mimicking after ovulation. Good? Okay. So it proliferated, estrogen or progesterone was being secreted in the proliferative phase to keep that endometrium nice and thick. And then the menstrual phase, assuming there was no implantation, that lining is shed. So you can connect the ovarian cycle, where you have the follicle developing on days 1 through 13, ovulation typically on day 14, and then the luteal phase is when the corpus luteum is secreting that progesterone. So we can connect these two concepts together. And don't worry, there's going to be a nightmare chart coming up for this. It's great. I shouldn't say nightmare chart, it's a great chart. This should be a review for you. You should remember from endocrine lecture that your anterior pituitary gland releases follicle stimulating hormone and luteinizing hormone. So now that you know what follicles are, what do you think FSH is going to do? It's probably going to stimulate that follicle. That's all I'm looking for there. So follicle stimulating hormone is going to stimulate the follicle to do something. We'll see in a second what it is. And what about luteinizing hormone? What did we learn about today that's luteal? The thing. Yeah, what's the thing? The circle. What? The yellow thing? That releases progesterone and estrogen. It's written right there. You can just read it. Corpus luteum, woohoo! So the luteinizing hormone is going to support that corpus luteum. Now, elevated levels of FSH or LH will have an inhibitory effect on further release of these substances. It should peak and then it should go away. There's also a substance known as inhibin that is going to inhibit further release of FSH and LH. So this is what this chart looks like, and we're going to walk through this chart a few different times. Here's the important takeaway. There's that follicular ovarian cycle, right? There's the follicular development, there's ovulation, there's the corpus luteum, there's the corpus albicans. So we call this the follicular phase and the luteal phase. Before 14, it's follicular. After 14, it's luteal. And that's just referring to what's active. The follicle is active, the corpus luteum is active. Day 14, we always mark as ovulation. So imagine this line going all the way down this chart. So that day 14 ovulation is a very important marker for us. FSH and LH are going to peak right before ovulation. And the simplest way to think of FSH and LH is that they trigger ovulation. They're going to be our body's sign, okay, time to ovulate. Now let's look at what estrogen and progesterone are doing. Notice they both have peaks in the luteal phase. So after ovulation, both estrogen and progesterone peak. We already know that's because of the corpus luteum releasing those substances. So that's there in the secretory phase to keep that endometrium nice and thick, like a nice bloody pillow, right? We like bloody pillows for things. It's not the last time I'm going to say bloody pillow. Oh, all right. There was also a peak of estrogen before ovulation. So the single most important hormone in the birth control pill is progesterone. If we can mimic this peak right here, then your body is getting the signal that it does not need to release FSH and LH and trigger ovulation. Okay. And again, we connect the functional and luteal, we connect the hormone levels to the uterine phase, menstrual, proliferative, and secretory. So I'm going to go through those highlights one more time. Yes, question?
So if you're on birth control, would that progesterone peak like just always be there?
It'd just be always high, yeah, except for the break week.
So question.
Which break week seems to not be medically necessary. Yes?
So how does birth control get around ovulation, but you still can have a menstrual flow?
That's a good question. So you still have that peak of estrogen as you have that sort of secretory phase. You still have other sources of progesterone as well. Some women do experience lighter periods due to this as well.
Ovulation, if you just don't get it.
Yeah, I know. I don't have every answer for you right now. We can look into it in more detail in a bit if you want. Okay, highlights. Functional phase is going to be pre-ovulation, and that's going to correlate with menstrual and proliferative uterine phases. Ovulation at day 14, LH and FSH peaking right before ovulation to trigger ovulation, and then staying low the rest of the cycle. After day 14, the luteal phase, the corpus luteum, is secreting progesterone. That means you've got a peak of progesterone and estrogen, and that also correlates to the secretory phase of the uterus. Does it all make sense? My goal right now is for it to make sense. It'll still take work to learn and memorize, but this is a very important chart. It's not the last time you're going to see it. It's definitely not the last time you're going to see it as healthcare practitioners. I know we're getting to lunchtime. I'm going to try to get a little bit further before we stop for lunch. So again, the vagina is strictly the internal feature. It does have a mucosa muscularis and an adventitia. Notice it is embedded in the pelvic floor. So it does have an adventitia separating it via connective tissue to other structures. The mucosa is non-keratinized, stratified, squamous, epithelium, and thank goodness, because what would happen if it was keratinized, stratified, squamous? It would just slough out all the time. That would be pretty gross. What's the purpose of non-keratinized, stratified, squamous epithelium? Prevent friction or injury due to friction. Absolutely. The opening that is visible from the external environment is the vaginal orifice. And oh my gosh, we're going to watch a video about the hymen now. Yeah, let's just go watch that video. So the video we watched was Adam Ruins Everything, The Truth About Hymens and Sex, posted by True TV. And it mentioned that the hymen is very, very poorly misunderstood. It is not a membrane that covers the vaginal orifice. It, in fact, is just barely two membranous folds around the vaginal opening that is in no way completely covering the vagina. And it frequently does not even break during intercourse. That'll be it, and then we'll go to lunch.